Good morning in Washington, D.C., good afternoon in Tripoli, and welcome all to indeed an extraordinary panel discussion with a medical experts from Libya who are with us today. We have a lot to cover in this limited time, and I'll start then right on introducing our distinguished guests so we can learn plenty on this important topic, especially during the COVID-19 pandemic. But also to be able to wrap up before the iftar time, an evening meal to break the fast in this holy month of Ramadan. So to all of our viewers in Libya and those of you around the globe of Islamic faith, I wish you all Ramadan Kareem and best wishes for the upcoming Eid al-Fitr celebration. Warm welcome to our panelists today and thank you for being with us. Dr. Haider El-Sayegh, who is an epidemiologist. He lectured in epidemiology and community medicine at the University of Tripoli. And in addition to this role, Dr. Haider serves as an advisor to the Libya Ministry of Health's Primary Health Care Institute and International Cooperation Office. Dr. Haider is also a member of the High Advisory Committee to combat COVID-19 pandemic in Libya. He holds a master's degree of public health from the University of Tripoli. Dr. Murat Gru is a professor at the Faculty of Medicine, University of Tripoli, and also a consultant at the Tripoli Medical Center, chair in the General Healthcare Council of Libya, and an honorary senior clinical lecturer at the University of Manchester. He is a member of numerous professional societies, both in United Kingdom and Libya, including a fellow at the Royal College of Physicians of London and a member of the Royal Society of Medicine. An expert in respiratory and critical care, Dr. Gru studied medicine at the University of Tripoli and also received a special training at the University of Oxford. Dr. Taher Mahbez is an epidemiologist and also a member of the Higher Advisory Committee to combat COVID-19 pandemic in Libya. He is consulting the Ministry of Health and is giving lectures as a professor at the University of Tripoli. Prior to this, Dr. Taher was the head of a health system reform committee, and outside Libya, he serves as a health advisor for the German Society for International Cooperation. He has been educated both in Libya and in the United States, holding a Master of Public Health from the Benedictine University in Illinois and a bachelor's degree from the University of Tripoli. Dr. Mahbez has also completed a research fellowship at the University of California in San Diego. Professor Dr. Samir Sagar is a graduate of the medical school in Tripoli. He is the fellow of the Royal College of Surgeons in Edinburgh, and he served as a consultant orthopedic surgeon and professor of surgery at the Tripoli University, and also was a head of the orthopedic department at the Abu Salim Trauma Hospital, and later on at the Tripoli Medical Center. Professor Sagar is also a former chairman of the Libyan Health Systematic Strengthening Program that's funded by the European Union. Currently, he is a director at the National Center for Health System Reform. Last but not least, Dr. Ghassan Karem, a Libyan physician who has been working in different locations and positions in Libya, including primary care center, emergency department, internal medicine department, diabetes center, and intensive care unit. He held many management positions at the district level, from health information, health service office, to a head of an emergency department, and later as a director general at the Ministry of Health. In addition, Dr. Ghassan is working in the field hospitals near conflict lines and in internally displaced people camps, clinics as a volunteer. He has witnessed several conflicts in Libya since 2011 and sees the impact on the human mental health due to consequences of war. While the health system in Libya is collapsing and becoming unable to respond to people's needs, as Dr. Karim suggests, and he's also a part of the political planning process at the national level in Libya. Ahlan wa sahlan you all, Thank you for being with us today. And perhaps this last sentence of alarming, if not to use the word collapsing health system in Libya, is somehow setting the tone of our discussion today. Where we are at, what has to be done, what is the health master plan, what the reforms are needed for Libya to succeed in creating a good healthcare system for its citizens. We'll start with you, Dr. Haider. Welcome all again. Microphone is yours.
Thank you, Dr. Sasha. Thank you, and I'd like to thank our colleagues who have been here during Ramadan time, and I would like to thank all your colleagues, Sasha, in the Transatlantic Leadership Network for giving us such an opportunity to talk about the health system reform. I would like to go briefly on the history behind the health system reform, at least from after 2011. As you know, all after the 42 years rule of Gaddafi, which was brought to the end on the 23rd October 2011, following a period of interim rule by the National Transitional Council at that time. After that, on July 2012, Libya had been the first election since 50 years. Then 200 members have been elected to form what called at that time the General National Congress, GNC. After that, uh, 500, I guess, experts from Libya, physicians, doctors from the academia, they did the first national health system conference, which took place in Tripoli at that time in August 2012. While the main topic and the main reason behind this conference, it was definitely the health system strengthening, the health system reform. Apart from that, not only Libyan who have been there, but also some international communities agency, such as UN agency, WHO, EU, and other donors, they were there. As a response to this conference, European Union took the first initiative and decided to support the health system reform and under a project at that time was implemented by GIZ, the German agency. It's called the LHSS, which is stand for the Libyan Health Certifying System. So this is some kind of the history behind the health system reform. So, however, now Libya, we definitely need the health system reform. And after this 10 years, we still really in need of the health system reform for mainly two reasons, I guess, from my perspective. In the post-conflict environment, health system strengthening can play a major contribution to both uh, as SDG, social stability and peace building. It has been long recognized that the public services provision enhance the government performance, legitimacy, a perception of responsiveness, thereby reducing the societal susceptibility toward conflict, as simple as. Also, a health system strengthening a driver for economic growth, which is the forefront of the agenda, I guess, for the newly government, the unity government, headed by Mr. Dbeiba. So I guess improving population health and job creation are mutually supportive objects. So good health has a positive, sizable, and statistically significant effect on aggregate output. While in contrary, as we all know, poor health generates an economic burden to individuals, to countries, institutes, and particularly unhealthy population generate higher healthcare costs and the financial risk, which hinder economic growth with high out-of-pocket expenditure and the public expenditure. And I guess I will stop here. Then I will give the floor to my colleagues to continue, and definitely we will discuss main hot topics that we need to cover under this panel. Thank you, Dr. Sasha.
Thank you, Dr. Haider. Indeed, very good beginning of understanding from the historic time of the nature of a health system. I'm sure we're going to go deeper in this later. And now I'm privileged to invite Professor Dr. Samir Sagar, who will be our second panelist. Professor, microphone is yours.
Thank you very much indeed. Many thanks, Sasha. You can see my slides, right? Thank you for the invitation. Welcome to you all. I thought I'm going to talk about the current situation, or perhaps the future plan to what to do about the health system in Libya. In the NCHSR, we thought that the principles of reform of the Libyan health system would depend mainly on good governance, universal health coverage, and proper health finance. Now, the current situation is that the Ministry of Health is responsible for all components of health systems. It is the governance body, it is the financier, and it's also the service provider. And this is the main defect of the health system in Libya. It's also the governance of the health facilities and health administration is mismanaged. And therefore, we're looking forward towards a proper governance by splitting the three components of the health system, and also a proper governance of the health institutions. Therefore, there should be no conflict of interest between these institutions, and there should be a clear separation of powers. Now, there are a few examples I would like to just to touch on, that an institute that is responsible for defending professionals, for example, should not be the same institute responsible for defending the population in front against or towards the provider. I'm talking about syndicates versus regulatory body for the health professionals. The other example is that the institute responsible for examination and certification and assessment of the training should not be the same institute that's responsible for the training itself. There will be a conflict of interest in this. For the universal health of coverage, the principle is to uncentralized or decentralized service provision. And it's based on the primary healthcare level. Now, as we all know, decentralization is thought of in the form of deconcentration, delegation, or devolution, and we've got a vision in that we have 6 integrated health regions in Libya. In each health region, it will be big enough to be viable and small enough to be manageable. These health regions will be able to provide the 3 levels of health services. So there will be the primary, the secondary, and the tertiary level in the same region. And that has been established. We have now 6 regions in Libya. Delegations is this culture and this understanding of the importance of having independent institutions within the Ministry of Health that will be responsible in certain subjects, certain tasks. Like, for example, we should have an institute for primary healthcare responsible for primary healthcare, an institute for accreditation of health facilities, an institute for training, postgraduate medical training, and so on, pharmacovigilance and drug information. So it's important to have tools for change, and these tools are the institutes. they will follow the governance stuff, but they will also be able to do their own functions. Now, devolution, in Libya, we have the Law 59 for the local governance, and that gives the, the, um, the function of um, the first level, the primary healthcare, especially the public health part, to be run by the municipalities. And therefore, we think at this level, there could be a possibility of devolution of some of the Ministry of Health functions to municipalities. As far as the primary health care, we found there's been a lot of problems with the primary health care in Libya. In fact, um, the idea of the importance of the primary health care has been quite some time in Libya, but it's never been managed properly. There are all sorts of bodies that are responsible to run some of the stuff in the primary healthcare level. And therefore, we thought it's important to classify the level of primary healthcare into two clear subjects. One is for the family medicine and one for public health or social or community health. Now, the importance of this for two reasons. One is to facilitate the devolution part of the cover by means of one will be a Ministry of Health institutes, and the other one will be more like a municipality institutes. It will be run by the municipalities, that's the public health part. But it's also because of the Law 20, year 2010, for the health insurance that clearly classify the funding of family medicine as compared to funding of public health. Public health is funded by the government budget, while family medicine is governed by funded by the health insurance. Therefore, it's very important to have these two clearly defined primary healthcare level divisions. As far as health finance, of course, health finance, to have a robust health system, you've got to have a proper health finance. That funding of the health should be sufficient. It should also be sustainable, and it shouldn't depend on one source like what you have in Libya now. What happened in the past is that whenever the oil prices goes down, whenever we've got a problem in oil production, the whole budget of the country falls down, then the portion for health will be too little to be able to run the services. But also, it should also be sustainable. And here, we know in Libya, we have one thing fixed, and that's salaries of the public health. And if you depend on your health insurance finance on a percentage of that fixed salaries, then you would be safe. You'll have a sustainable health finance. So we introduced a public health insurance fund recently that is now it's ready to act. It's legitimate, it's clear, it's institutionalized, and it's got its own setup now, very clearly defined. A part of the health insurance, health finance thing is the problem with the salaries, the payments. And we've been trying so hard over the last 3-4 years to establish a payment system whereby people are paid for services or paid for performance. The current compensation way is flat salaries is useless. We all know that if you don't have any incentives, if it's not clear you're paid for what you're doing, you wouldn't expect a good outcome. The management of health facilities should depend on economic basis. Now it's not. Now they all depend on budgets that they will be ready to spend as soon as they get the budget. There's no clear budget lines. So the national health system, national NCHSR has put forward a 3 years health action plan, whereby we should be able to start the institutes that I like to call them as tools for the change, but also change the legislations that we think need to be changed. And I think we've done, I would say, 70% success or so, in spite of all the problems that we face in the country, as you know, both political, military, or health-wise with COVID. Now, this is Libya with its 6 integrated health regions. And this is the integrated health region with the 3 levels, where the splitting the providers from the governance body from the finance, clearly defining which to be funded by the health insurance and which to be funded by the government, and which to be run by the municipality or with the public-private partnership or the universities. So thank you very much indeed.
Thank you very much, Professor Sagar. A lot to process and certainly to discuss later on in our joint discussion. Thank you again. Dr. Taher, would you join us, please, with your remarks?
Yes, thank you, Sasha, for letting us talk about this important issue in Libya, which is the health system. So I'm going to talk briefly in general about the health system. So when we talk about the health system, we first should know what is the aim of the health system. So the main aim of the health system is to improve the health of the people, not only through the curative treatment, but also through protection and promotion of the public services. The other thing, it's the health system is built to protect people against the financial risk and to provide equitable access to the health services. And it also should enable people to have a decision on their health, because we're talking about the health of people. From that, when I was in a college, I was thinking that the health system composed of 3 things, which is like the payer, which should be the government or the insurance, and the provider, and the client, which is the patient or the one is seeking an advice. But when I started my master degree, I realized that there are like many subsectors in this system, which I would like to elaborate here. That there are like 2 main models that I know that all my colleagues know about them, which is the World Bank model, which is the 6 building blocks for the health system, which composed of the service delivery and human resources, the financing, the information, the health information, the medical equipment and the drugs supplies, and the governance. So if we did divide the health system to those sectors or to do those building blocks, then we can use that to analyze like the health system. The other model, it's the World Bank model, which is mainly focused on the financial issues, and it calls the control knobs of the health system, and it's composed of the financing knobs and the payment knobs, the organization knobs, the regulation knobs, and the behavior knobs. And both of these models, they do have an outcomes, which is the health status of the people in the country, and satisfaction of the customer, and the risk protection, which is financially or social protection. So one of the main challenges here in Libya is the lack of data and lack of research on the health system. So if we're going to do a reform, or if we're going to do strengthening the health system, we should know where exactly the problems here. We need some researches. We need some data actually, which will give us a real evidence, the performance of the health of the current health system. So for me, it's very useful to use those models to analyze the system, to exactly know each component of the models, to know exactly where is the defect and where is to do a reform or to do an improvement for that. And I'm sure that right now all the health system will need a reform after the pandemic. Actually, a lot of health systems the pandemic shows the gaps in the health system all over the world, and most of the health system need to do a reform in the providing, the system, the payer, and the government. They have to consider all of those things. So it's good. It's crucial actually to do a research and to do data gathering, which include the input and the process and the output actually, which will be helpful for us, for everyone, to know exactly what to do and actually to do the priority things. We don't do a reform like in 1 year or in a sudden. We do it in gradually and in steps actually. I will stop here and let that the discussion for other topics and let the other colleagues comment. Thank you, Sasha.
Thank you very much. And now, Dr. Murad, and your opening remarks, and then Dr. Ghassan, and then we'll start talking jointly.
Thank you very much. My colleagues covered, I think, a lot of topics and issues. I guess my remarks will be general remarks, really. The healthcare system leaders in Libya talked about health system reform for decades. From the time the biggest investment was in the 70s, and the system worked very well for around 10 years. And then, because of multiple factors that it takes long time to explain, but the system started deteriorating, and people started talking about reform. And there has been multiple projects since then. Most of them, or virtually all of them, were systematic analysis and review, which led generally to list of problems and proposal of corrective actions. But we always failed in Libya in the implementation stage. These projects remained in offices, and after 10, 15 years, they get forgotten about. And that's a problem, because even this stage gets repeated again and again, as if nothing has been done. The problem in implementation is quite complex in Libya. Why we don't implement these changes? I guess number one is the traditional resistance to change. And everybody who works in healthcare management or know anything about management anyway knows about resistance to change. It's something natural. It happens everywhere. But in Libya, we go to different scale. The scale of resistance in Libya, I've never seen, and I've been involved in health system for a long time, and the scale of resistance to change is just unbelievable. I guess one of the reasons for this level of resistance to change is the systemic corruption within the system. The system is orientated and designed to facilitate corruption. And people get into the system with good intentions, and they are not naturally corrupt. But the system is corrupt, and it corrupts people. And then it inherently resistant to change the system. And people also become major resistors because of multiple factors: loss of power, or risk of loss of power, loss of earning, and so on. So we ended up with a system which is really very old-fashioned, not fit for purpose. And one of the problems that people faced is because of the delay or inability of the system to develop, there has been no major change from the 70s till now, or till the last few years. And then you ended up with a system that is inherited, which is very old, very corrupt, and it's difficult to evolve with this system because a lot of voices are calling for gentle evolution, trying to correct problems slowly, because this is usually the preferred way. We all prefer this method. But in order to evolve with a system slowly, you have to build this evolution process, or this process of development and improvement within the system, so it continue to catch up as time goes. But if you stop at certain point for 2-3 decades, you have to make a big jump. And that's why we thought in the LHSS, the European sponsored the program, and I was privileged to be the co-lead expert for this program. And we tried to think about a way of evolving the system, but we found that theoretically it is impossible, and looking at previous experiences, it wasn't possible. And we have to deal with core problems within the existing system. In my view, the core problems are this systematic corruption based on lack of transparency, lack of accountability, and lack of a system for quality assurance. And these are the mechanisms that stops corruption anyway. And a corrupt system naturally will have none of these, or will try to minimize these. And in order to achieve this, the LHSS program felt, after multiple conferences, multiple consultations internationally and locally, is that we have to separate funding from service delivery, from regulation. And without this, the system will not be transparent. Without separating these three components, the system will not be transparent. In moving towards health financing system based on social insurance fund will promote transparency. Moving to a system where the regulatory powers are all or the majority of it is under the Department of Health and becomes the main role of the Department of Health, will promote accountability, because the Department of Health will decide what are the standards, what are the rules, and inspect and assess and license and so on the basis of this. So there will be accountability and competition between public institutions and private providers on the basis of financing through health insurance funding will drive quality. So quality will inherently improve, even though the formality of quality assurance is part of the regulatory system, which should be under the Ministry of Health. So my colleague, Professor Sagar, talked about this, and we are proud that we got this for the first time since the 70s into a stage of implementation. And that's why we established the National Center for Health System Reform under the Prime Minister Office, and the plans of the LHS was taken forward, and Professor Samir talked about the implementation tools that we try to establish under his leadership. And I guess my last few sentences is that we really don't need more studies of the healthcare system. We've done so many of them. We don't need people to list problems, because we got really very big list. Each one of my colleagues can produce pages of lists of problems. But unless we start tackling these problems, unless we start implementing, we will get nowhere. And that's why a lot of us dedicated their time freely to try to drive this forwards. And my call to international institutions is to stand behind this, not to take it project, not to take it as something absolute. I mean, this is not written in Quran, and this is not something came from the heavens. This is something developed through consultations. And as for any projects, normally there will be problems which will come up as we implement this, and we have to deal with it. So even at analytical level, people who wants to help with analyzing situations, we want them to help to say critique this proposal, try to see if there is any gaps, if there is any problems that they can help with. But we really need to drive this forward, because without separating whatever, I mean, people may decide that there is different way of separating these three components: financing from health to provision, from regulation. We thought this is the best way forwards through the proposed system within the by the LHSS and then the National Center for Health System Reform. But our proposal was not based on just random thinking. It was based on what happened in the rest of the world. And if people have different views, then they're welcome to talk about it. But without transparency, accountability, and quality assurance, we will get nowhere. And that's the end of my intervention, I suppose.
Thank you so very much for these brilliant remarks. Highly appreciated, and a lot of ground that we will all talk about that you also brought in now. And last, but definitely not least, Professor Dr. Ghassan, microphone is yours.
Thank you, Sasha, and thank you to Jonathan and all your colleagues for arranging this webinar. I'm so delighted to be here with the colleagues. not only to share, but also to learn from the colleagues and also from the audience. So I'm so happy to participate in this discussion. And my colleagues, maybe they elaborated most of the areas around the reform, but I want just to emphasize, Sasha, that reform is not limited to one health system, or that Libya needs reform because it went through a conflict. Reform is a necessary process for every health system, because I believe that there is no perfect health system. All countries, they need to work on their health systems and improve the performance of their health systems. And this was one of the problems before 2011. Because if you talk that the system needs to be improved, that means there is something wrong with the system. And that was not really acceptable thing to say. But after 2011, it was the window of the opportunity. So people, they can talk loudly about changing the system, improving the system, implementing a reform. But you need to keep in mind that reform is a dynamic process. It's a iterative process, complicated, sustainable, but also interesting process. And I would say that the EU or the international aid played really an important role to initiate the process. Even though I would support what Dr. Murad and Dr. Samir were saying, that reform ideas were in Libya a long time ago. But the real initiation started after 2011, because this window of opportunity, it was supported by the international aid. But unfortunately, the international partners, they focus more on initiation of the process, but they cannot do much during implementation. And you know, reform is a long-term process. And usually those projects which is funded by international partners, they look usually for quick wins. They look for low-hanging fruits. And that's something not related to health system reform. And I will add to Dr. Murad, because he was talking about very important elements that we need really to implement, but also we need to remember two keywords. The first one is the national ownership, and the second one is the national leadership. If the country, they don't have the national leadership, so they can take the steering wheel and lead this reform project, and if they don't have the capacity to absorb all the evidence from other countries, or even the nationally generated evidence, and use that to develop the system, then we will not move forward. And sometimes when you use international aid, it's important. Yes, they bring experiences, they bring supplies, they bring tools, but sometimes they enforce policies. Sometimes they impose priorities, especially if you don't have the national ownership. And I would say that since 2011, there was a frequent turnover of ministries, which was a major challenge in Libya, because this frequent turnover of ministries, it's a barrier to implement the reform, because every government, they know that they will stay for 1 year or so. They will look for something very quick win. They will not invest in a long-term reform. This is a project for 4 years or 8 years government. It's not a project for 1 year government. And when the government or when the national leaders, they don't really believe in reform and they don't really want to do the reform, then nobody will do it. Regardless how many international organizations or international partners will advocate or will advise to do reform, nobody will do reform. Because Dr. Murad was saying there is a problem with implementation. I will say that a big part of reform is about resource allocation. So you can talk theoretically about reform and everybody will say, okay, this is a good thing. When it comes to resource allocation, then no, there will be a resistance. Because nobody will think about changing the finance or the priorities when it comes to service delivery or human resources or whatever. And that's why it's really important that the national leaders who do control resource allocation in health sector, they need to believe in reform and we need to target them. Now, I know that there was a step forward and it was a big step forward when we established these new institutions. So now the reform is not only limited to some national experts and some international experts. Now it's represented in a national institutions, like the National Center of Health Reform, like the Primary Care Institute, General Health Council. These are very good institutions and they will support the reform project, but still they don't have a big influence on resource allocation, which should be our next step. And I will just say that there is like a very strong connection between the establishment of institutions and gaining the trust of people. We need to gain back the trust of people into the national health sector. And that's why we need also to work on community mobilization and on mobilizing the people and trying to use their power to influence decision makers and to make them really working on how to fix the system, not only how to provide services on the short run or only how to provide supplies, but we need a sustainable solution for the health sector problems in Libya. I would say this, and thank you so much for giving me this chance again, and back to you, Sasha.
Thank you, Dr. Ghassan. Well, we have interesting ideas to, some may be confronting as I could see, to try to move forward. I will ask the very last question about the COVID. I will not discuss it at the beginning, although all the world is with COVID, but let's go right to what you've been all discussing. So my sense is nobody argued that reform is not needed and that the health system in Libya is in a good shape. I think it's very true. Every country in the world, from the United States to the less developed countries, needs to do regular reforms. The question on local ownership, the question versus national leadership, where is Libya today? Without discussing politics of your country, but you have now 1 year government elected to first and foremost prepare general elections mandated as such by the UN process, but the Prime Minister vowed to do a lot to improve the overall being and life of Libyans who throughout the country suffered really a lot continuously from 2011. So you still have hesitance to approve the budget that was required. There will be a lot of political back and forth on state level. Personally, I always say better to negotiate years, but not to have one life lost being killed in any fighting. So I think Libya today, than Libya last year, this time is in a different place, and I hope this continue moving onward and upward. But we also witnessed that on a various several municipalities, the local development project proved to be successful. So while you have these political fight on a state level that sometimes or very often doesn't have the interest of people at their table when they discuss these solutions, is it possible? Two questions to you all. Is it possible to incorporate the good governance experiences that Libya had, even in these turbulent times, on a local municipality level? So to suggest the system where they would be able to have a power over separation of these three components that Dr. Murad was talking about, so that you create municipalities that can take an example lead in providing better health care for their constituencies, in which, for example, as maybe I'm wrong, you may correct me, I've been to Libya many times, but city of Garian, for example, I think it's a 200,000 people living in Garian, became internationally famous during this latest war problem. I had the privilege to meet the young mayor of Garian in Tripoli in 2019. But as I understood, there is only one hospital serving the populations in the city of Garian. So if, for example, you can create the law that will give the local community enough budget, enough management control in respect to to succumb the corruption and at least minimize it in order to improve the health care for local communities. And then through that, hopefully, that eventually this would strive on the national level and throughout all the regions and cities in Libya. I think we can start from the very same order we were talking, so you can just go one another, and let's start with Dr. Haider.
Thank you, Sasha. Thank you for this question. Actually, I don't know if we could answer it in shortly, but I guess this is controversial. You know, we are talking about municipality. It's also too risky on hands of municipality themselves. I don't think that now, currently, municipalities, they have the capability and the capacity to run such hot topics, especially if the financial law of the government is still relying on chapters, you know. For instance, I will give you a small example here. If 90% of the budget is being allocated for the HR, for the human resources, and you have only 2 or 3% for developments project. So what can mayor do with this budget? Nothing. Unless we could change to do a bigger change in the financial law of the government, nothing will happen. And here you need to include definitely the Ministry of Finance, Ministry of Planning, the Prime Minister himself. He should sit and discuss those hot topics. Another point, which is also too sensitive, I guess, here, which is the law 59, which is the law that give authority to municipalities to handle all the national sectors like education, economy, health, whatever. And recently, I guess the former deputy of health, he made like some kind of resolution to give some kind of authority to municipalities, but now the current minister, I don't know, he declined, I guess, this resolution. So maybe he has a point of view here. Maybe this is not the right time to give municipalities this hot potato, you know, because as I said, they don't have capacity. Definitely, you cannot compare, for instance, Ghrian. So what we have more than 200 municipalities in Libya. I don't think that they have the capability, and I've been working with municipalities in the last 5 years as I am an M&E consultant. So municipalities, they are receiving whatever, and they are directing. So for, if they, at least if they could develop their priorities, their needs, so I don't think that you can wait more rather than this. So again, so what's the solution now? What's the solution? I guess now, if the government wants to interfere here, I guess this is the size and the scale of the reform. It's too big for anyone to digest. This is my perspective here. The scale of the reform, it's too big for anyone in Libya to digest. So unless we could divide it to the small portions, and let's divide it into the next 5 years, and in each year we take like small plenty thing that we could implement on the ground. Otherwise, as it is now, we are talking about the finance, we are talking about the health information center system, we are talking about the drug and therapeutic use and governance. It's too big for anyone to handle it in Libya, and we don't have the right people because it's high turnover authorities. We couldn't set like a government for 5 years, 4 years. So with this interim period, nobody will take this risk and do this gambling to do such kind of reform. So this is my answer. Thank you.
Thank you, Doctor. Professor Sagar, what is your take on this?
Yes, I agree really with Dr. Haider. I just want to add that for a reform to succeed, you need to have a political will, technical will, and administrative will, and know-hows as well. Now, the municipalities can help with the political will, but we want to make sure that they can they've got the know-hows for the technical and the administrative as well. Now, and as Dr. Haider just mentioned, that you cannot really compare municipalities. Some of the municipalities are only 10,000 population, and others are 500,000 population, like Benghazi and Misrata. So this is one of the problems, and this is really one of the mistakes that has happened, even in the 206 and 208, where they've tried to do something in the what was called Shabiyat, governorates. There were 23, but some governorates are only one municipality, and others are 13 municipality. So, and therefore, and starting from where Dr. Haider end, you've got two choices. Either you've got to pilot your reform work. Either you, as Dr. Haider just said, you choose some of the services and you implement them gradually, or you take all the reform measures and you implement it in one region. And that's why we've got a project now to be presented to the new government, is to apply the health system reforms in the southern region. We've got a population of 500,000. We've got clearly 14 municipalities. We think that the service there is zero. You cannot get any worse. So it's likely that the chances that it will succeed is very high. And then the General Healthcare Council can work there. The accreditation center can work. The postgraduate training can do their job. The health insurance and so on. And when that succeeds, then you can, pass it over to the other regions. Thank you very much.
I have to tell you that personally, I was very happy to hear this. I didn't know, and the South is usually always less visible in many of these issues. I'm very, very happy to hear, inshallah, that gets approved. Professor Dr. Taher and Dr. Murad, and then Dr. Ghassan, three of you on best ways, actually, I think, to see.
Yeah, I'll talk first, actually. So, yeah. So I agree with my two colleagues, Haider and Professor Samir. We should know here that the health system is just a part of the country system. And in order to do a reform in a proper way, we need to change some things, some technical things, or some laws in the country. For example, as Dr. Haider said about the financial law, which is an old one, and it needs to be amended or changed actually to be able to implement actually the reform, the health system reform. What I see from my experience, we had a lot of projects that intended to do like a decentralization of the health to some municipalities. But the problem is, as Dr. Samir said, there has to be political will and technical will and administrative will. What we ended is we stuck in the pilot project. Actually, we do the pilot. Sometimes it succeeds, sometimes it's not. But the thing after the pilot, what will be? So we stuck in the pilot phase. We didn't continue after that. We do have some experience in doing some decentralization of some of the health services in some municipalities, but after that we stuck. We stay in the same step. What happened is, as Dr. Haider said, that we had a lot of governments, and it's not easy to explain the health reform to all of them after one after one. And all of them, they do have some new ideas, they do have some new things they want to do, and which will affect the reform if we're going to have like political instability in the future too. Yeah, I think this is my comment, and I will leave that to my colleagues.
Professor Murad?
Thank you. Yes, I strongly support what has been expressed by colleagues. I think it is really difficult to devolve to the level of municipalities because of the major differences between this. I mean, the big gap between the smallest municipality and the biggest one, and some of them are 500,000, and some just a couple of a few thousands. So it's really difficult from that point of view, but also the financial model. Like what colleagues have been stressing, the financial model, that the money comes as, in health services, the bulk of the budget goes to the workforce. But the system, by stealth, the health and education services, both sectors, are acting currently as a social welfare system as well. So a lot of people are getting salaries but doing no work. And staffing is so bizarre, I suppose, if you look at it from this angle. One good example is you will find in a municipality, for example, a healthcare center with one doctor and two nurses and 80 or 90 administrative people. And basically, those people are there. If you will implement a model by which you pay for performance, or you pay for the service, then all these people will be out, because the income of that center will be just probably enough to pay the salary for the doctor and the two nurses and maybe one administrator. But you got 60, 70 getting salaries from the system, because the system is doing this job of the social welfare. They're getting that salary. So I suspect personally, this is really the elephant in the room. No reform can be done within the healthcare system or the education system without tackling this problem. And we saw this in Ministry of Education a couple of years ago. One very enthusiastic health education minister, Dr. Othman, Othman, I think, I forgot now the name, but Abdul Jalil, Dr. Abdul, he wanted to reform the education system. He said, we have teachers earning salaries, but they're not even going to the school. They probably don't even know to which school they're supposed to belong. And he basically distributed the questionnaires and so on, and he wanted to just keep the people who are really working and people who are providing lessons and so on. And the whole thing became complete chaos and ended up with his resignation. I think he resigned. And basically, I think because people didn't think what to do with those people. Now, there was a previous attempt by the Libyan government during Gaddafi time, where they they assessed this excess capacity, and they moved them to the Ministry of, moved their files to Ministry of Labor, and they continued giving them their salary until they find different places for them. But the current problem is much bigger now. So at that time, the health services, their service employees were around 125,000. Now we are around 250,000. And we've got, basically the whole country is employed by either the healthcare system or by the education system. And if the government doesn't tackle this problem, devolving the finances to these levels would be impossible, because from where you will get the salaries. Now, I think with financial support, and with accommodating these anomalies, yes, we can implement this project or this reform within the South. And I think there will be a problem in terms of this excess workforce, and we have to think about the solution for it, because this is a very hot potato. It's quite difficult, because people in Libya see the salary as a sacred thing. You can do anything you want, but don't touch the salary, because the salary is for the family and for the children, and you will be starving them, and that becomes, the whole thing becomes emotional and so on. So I guess what I am saying is just a clear evidence of how the health system interacts with other parts of the government or the state systems, like the education system, the finance and planning and so on. So if it affects every sector, and the best way of reform is to reform the whole thing. But if Dr. Sayah is saying reforming the healthcare system is this way is very big and difficult to digest, then if you try to reform the whole country, other systems in parallel, then that's even bigger. And we are really in difficult position. And I think nobody can envy any person or leaders involved in the reform, because it is mountain, climbing a mountain. Well, not, I mean, it's more than climbing a mountain. It is something titanic. But the problem is it has to be done, and people left it too late. Actually, I think people were quite, I mean, sometimes very fearful because of all these things. So you say, well, because of this and this and this, let us just carry on now and postpone reform to later stage. And then the situation become worse. And then the same thing happened. And I suspect one of the problems, and I haven't talked to colleagues who were involved in this, in reform in the last few decades in much more detail, but I suspect one of the problems faced them was fear from these difficulties, how gigantic this job is. Thank you.
Thank you, Dr. Mulad. And I would say, just to concur with you 110%, you can have a government for 1 year, you can have an interim government, you can have then a transitional government, you can have a transitional councils, and you can keep on the transitions forever. But the people needs to have a better quality of life. And I think every government has a responsibility to tackle issues that are important for citizens. And I think if this reform in South as such, maybe that could be used as a model. We will discuss this ongoing, and we'll produce your authorized thoughts later on that maybe can be shared also. And hopefully the Beibas government will look into it. I was encouraged to see the government going in the electricity plants and the solar plants, and they're trying to at least there is some better energy on Libya than, with all the daunting difficulties, than what were the topics of last year and the years before. So inshallah, let's past be the past with all turbulences, but the government and the professionals tackle on issues that are really of a consequence to life of Libyans. And so last, Dr. Ghassan, maybe your thoughts on way to reform the health system as it is today.
Well, thank you, Sasha, for suggesting this, and to start the reform at the peripheral level, at the decentralized level, not at the central level, is a good idea. However, as my colleagues were saying, because the system in Libya is very centralized and all big decisions, they are made at the top level. And that's why there is no much to do at the district level. But to add to what Dr. Haider and Professor Samir and all the other colleagues, they were saying, the problem is not only with that we don't have standardization for the municipality, that there is different municipalities with different sizes. It's not only that, but the number of the municipalities is too much. Libya is a small country in terms of population, around 7 million, but it's a big country in terms of landmark, more than 1.7 million square kilometers. And there is many people, they live in remote areas, even though most of the population, they live in the north, but still there is people, they live in the south and other areas of the country. And it's really difficult to start at the subnational level for another reason, which is, maybe you said that you met one of the mayors of Libya, but they have a different understanding for decentralization. Because usually the government, the ministry, at least the Ministry of Health, when they talk about decentralization, they talk about deconcentration, about giving away some administrative responsibilities and authorities. But the mayors at the municipality level, they are talking about devolution. They want political power at the subnational level. They want to make the big decisions like resource allocation and other decisions. That's why there is a big gap in understanding between the leaders at the top level, national level, and at the subnational level. But still, I would say that maybe we can start with 1 or 2 municipalities where there is a good population size. So it will be an efficient trial. So we cannot start at a small district, but maybe at a big district. And let's reach an agreement with the top level that we should give them some authority with regards to some decisions. So, and let's see how it happened. Like, for instance, what happened in Finland, they tried to reform their health sector, but also to decentralize the system. And they reached final conclusion where they brought some districts together to make it efficient. And it was not, as I said, it was not a one night process. It takes time. But Dr. Murad was saying, we will not regret that the efforts that were invested in reform, but also we need to be patient because this is a sustainable process. And maybe we have been trying very hardly at the top level. Maybe we need to start some trials at the regional level. You know, in Libya, there is the problem that there is too many municipalities, more than 110 municipalities, but there is no middle level. We don't have governorates, we don't have regions. So if like, for instance, a director at the ministry level, he or she, they need to communicate with the municipalities because there is no middle level, then they need to talk to more than 110 structures. That means they need to manage more than 110 districts. This is quite difficult when it comes to management, but also it's inefficient. And that's why we need to fix this. Yeah, that's what I had in my mind. Thank you.
Thank you, Dr. Ghassan. Okay, we are, you have around 40 something minutes before iftar, so I won't put it in a very last time to drain you, but let's, we will continue this, inshallah. We will, this is a really important topic for the Libyan people, I think, in every city, whether small or big or any village. I think this is a part of a bigger picture for reforming Libya and making it prosperous, stable, good functioning country. It does talk about the diversification of economy. It talks about putting a system that would make sense and that will be maybe uniquely Libyan. Maybe you will be actually creating a system based on the systems you had to the system that can become combination of centralized and decentralized, as long as the people will have a functioning normal health system. I think this is the ultimate bottom line of this discussion. So with these thoughts, your last comments, and how would you view the COVID response, COVID situation in Libya? Is it manageable now, better than at the beginning of a pandemic? And are there any needs that are yet to be addressed for the citizens of your country? Same order.
Thank you, Dr. Sasha. Yeah, I guess the most difficult topic than reform, comparing to the reform, this is the COVID-19 response. So you perfectly choose the, the two hot topics in Libya. So I would like to talk about the COVID-19 response, and if we could divide it into two phases, two main phases. Before the new government, this is an era, and now and ongoing. Before the first diagnosed case of COVID-19, it was on 24th of March 2020. This is the first case. And at that time, and to be honest with you, we faced a lot of resistance for public that they were neighbors to the main hospitals in Libya to accept those cases to those hospitals. And at that time, it was really a political willingness and financial willingness to establish a better system, which we called the isolation centers for receiving COVID-19 cases patients. And eventually, yeah, this is what happened. Libya, we developed more than, I guess, 94 isolation center for COVID-19, which is center with different capacities. I mean, in terms of the bed capacity, they are intensive care units, intensive care machines. They are ranged from some of them they accept 10, others they accept 200, and 4 and so on. So at that time, I cannot say now this is the right or wrong, but this is what happened in Libya. And I was a member of because now there's no longer any advisory committee to combat COVID-19. It was all in the hands of the minister himself, with the directorates of the MOH and the National Center of Disease Control. So there is no more any advisory committee to combat COVID-19. And maybe this is one of the reform strategy. I don't know. So at that time, as I said, it has two advantages at that time for developing the isolation centers. Number one, we didn't touch the public hospitals. So public hospitals, they remain active 24/7 as before, despite the fact that at that time, as you know, as a response to the pandemic, all the borders had been closed. So there is no treatment abroad at that time. So all Libyans really seeks any medical advice through the public system, it was a good step to regain the trust again to the public health services provided by the Ministry of Health. So this is the advantage of this developing those isolation centers. And the second thing, which is, I guess, it's some kind of equity between the cities. And we developed, like in each city, at least one isolation center to combat the COVID-19. And you know, Libya, it's a big country in terms of geographically talking right now. We developed at least like laboratory, one lab test, and the isolation center in the same time. So those were the advantage of developing those isolation centers to receive COVID-19 patients. So what are the disadvantages? Disadvantage, which is the HR, the human resource that they cooperate and operate those, came from the public. Most of them, they came from the public health sector. And when they came to the public health sectors, their renovation, their compensation and allowance, they were too big to handle it by the government in terms of sustainability. The government, they couldn't afford the amount of payment that they receive those staff who are working in the isolation center, and this led us to the interruption in the payment role, and we have been through to the strikes, resistance, and this is again, we lost the trust in the isolation centers. It's a controversial thing, you know, we gained the trust in the public health sector, but eventually we lost the trust in the isolation centers, and now they don't have a good reputation, those isolation centers, because of the interruption of the human resource and so on. So this is the history behind the COVID-19 response. Now, what? Yes, Sasha.
I just wanted to ask you, would you agree or suggest that there was also an issue of a corruption involved very much on people trying to,
Exactly.
if suddenly there was a new pandemic and some people apparently thought of it an opportunity for same old practices.
This is what happened. Literally, this is what happened. Because if you could measure the amount of expenditures on the COVID-19 pandemic, it's unbelievable. It's unbelievable. And me and my colleague, Dr. Tahir, were like members. We are headed the epidemiological component in terms of preventive measures, in terms of the preventive measures that could government and the country apply. So we didn't interfere because it has a lot of resistance if you could interfere in those financial. So we stayed for I don't know, our safety, maybe let's say it like this, to interfere with such kind dangerous topic, which is the expenditure, and who could expend to provide those kind of services, because it's something too big. I mean, we are like two physician epidemiologists working on
Would
I
you
don't
then
know,
agree,
break.
then maybe we can now jump into this conversation. Would you then agree on the proposition to separate these three segments that Dr. Murad was saying, so that
Yeah,
you create a system, at least in some way, that can diminish the multitude, because the people were really suffering at the beginning. You know, they were giving a lot of money towards the vaccines and the oxygen and the project, and it was a pretty chaotic, to say it at least. Anybody
exactly.
else? Anybody? Let's have a discussion among you on this. I will be very happy, because we are also pretty much constrained with the times. I don't want to really take a lot before
Yes.
iftar for you, so I appreciate it. Who want? Let's just open it randomly without order. Let's just talk.
I'll start from then. One of the problems in Libya, and it's applicable to most Middle East countries anyway, we don't learn from other people's experience. And Churchill said, and actually it's not his saying, it's one of the, I think, South American philosopher, but it's attributed to Churchill. But he said, those who don't learn from history are doomed to repeat it. And in Libya, we had the advantage of the epidemic starting late. Now, it started in China in December, in Europe in January, February. And in Libya, basically, the main wave started quite late, June, July, I think. And there was months. And there's a lot of knowledge accumulated internationally about this. And basically, Libya closed their ears and they came up with different solutions. And we always come with anomalous solution, something that unbelievable, something comes from absolutely nowhere. And then we implement it. And add that obviously to the corruption and the problems you already alluded to. We ended up in disastrous situation, as we always do. So I think looking forwards, we should all stand behind vaccines, vaccination. Even this, unfortunately, it's not going right. Well, I mean, not because of the people who are giving the vaccines, the National Disease Control Center and the people working on the ground. They're doing really great job. But but the supply is not guaranteed. We had discussions about vaccine supplies and how much orders need to be done and how many doses we need back in August. And I provided colleagues with data about European orders, and especially the UK, in very detail. I remember at the time, UK by August, UK made an order for 360 million doses for a population of 67. And the Libyans were talking about 1.5 million. And we said, no, you should. There is good reason why these countries are ordering large number of doses, and we shouldn't hold back. But even these doses, the 1.5 million, didn't mature, so we ended up getting donations from elsewhere, and even the small number of vaccines we had through COVAX, so far we failed to pay for their price. I don't know whether they paid now. By up to the 22nd of April, they haven't paid for it. And this is all because what Dr. Haider was talking about. So I'm not going to repeat it. But I think our solution, we have two options for COVID. Either we stand behind the vaccination program and everybody insists that the government provide the fund for the vaccine. It doesn't matter whether corrupt people make money from it or not, but just we need to get it to the people and vaccinate them. Or otherwise, it's natural herd immunity, I'm afraid.
Thank you, Dr. Taher Ghassan
Yeah.
and Professor Sagat. Your thoughts on COVID in short reflections, so that you can go and prepare yourself. We should wrap up soon.
Sure. Let me give you a brief on COVID response in Libya. And as we see that COVID shows the gaps in the system, which are many gaps there in the system actually. For example, when we look to the system, there's no emergency plan like before, like emergency preparedness plan for any disaster and any pandemic. And even if you look to the Ministry of Health, you'll not find any an emergency department until like 2019, and still they don't have any solid plan for any emergency, which is really what I see. It's very big gaps. The other thing, when we see in the last year, we see that there's the responsibilities for all the institutions and or the ministries that combating the COVID, it's interacting actually. Nobody knows where is their responsibility. What should they do exactly? Or someone do something and the other do the same thing. There is a doubling of responsibilities all over the country. They, because they don't have any like, let's say, like job description, something like that. And one of the main thing that the country doesn't have, or the health system, there is no like an indicators for the performance. Okay, so we did a response to the plan. What is the indicators? What is the how do we know that we succeed actually in our response to the pandemic? And one of the things that Dr. Murad is elaborating is the procurement, which is not for just the vaccine, but for everything, for the PCR, for the oxygen, for the let's say the protective equipment. We don't have any like sustainable mechanism for procurement. So, for example, let's see the other countries where the United States, I think they procured for, or they bought like more than 5 million of doses of the vaccine actually. And because they think that in the future they need more doses of the vaccine, like 3 doses maybe for we don't know exactly. But for us, like the government or the health institutions here in Libya, they think that, okay, we procure 5 million or 6 million to the people, and that's it. And then after that, if we need more, we go to the same story for procurement. We find someone, we look for vaccines. So we need something sustainable even for the procurement. But when we see the whole picture here in Libya, and when we see the indicators that the epidemiological indicators in Libya, we're even though there's some of like is like an estimated indicators, we're still better than other countries. We don't know exactly why, what happened. We don't say that the response is perfect or an excellent, but the data said that we're still in a good position compared to other countries. Thank you.
Thank you. Good to hear something also positive. Professor Sagar, are you joining in on this closing remarks? Anything?
In fact, I wanted to ask you to skip me on this.
Okay.
The last one you want to ask is on orthopedic surgeon. On no, but I'm going to say something very brief. Is that I'm optimistic that with the introduction of the vaccines and starting vaccines, and with the fact that now it's the function of the National Center for Disease Control, I'm hoping that things will be better, inshallah. Because I think a good health system with the state of institutions, you give this function to the institution that's supposed to do so, which is the National Center for Disease Control. And in fact, I'm one of those who wants this national center to be for communicable disease only, so that it will do it best. Thank you.
Good point, Professor. Thank you. Dr. Ghassan?
Well, thank you, Sasha. I would just say in summary that I think COVID-19 pandemic was not only a disaster, but it was a learning opportunity, and it's still a learning opportunity because it showed how much fragile is the Libyan health system. And that's why decision makers, they went to and created a parallel system to manage the pandemic. They didn't use the existing health system. They didn't really invest into the hospitals or primary care facilities or the existing financial arrangements. But they went and they created another system parallel with isolation centers and new payment contracts and new financing arrangements, new facilities, new equipment. And with every chance, they will go and they will create a new one, because every one of them, they don't really trust the existing system, and they know that it needs to be reformed, it needs to be fixed. And I think this is an important lesson that all of us, we need to admit that we need to work together on the health system in Libya. For COVID, it's like any other health issue. Most of the cases, they don't need inpatient care. Most of them, they don't need critical care. You can prevent the disease, you can promote health. You can manage mild cases, which is most of the cases at primary care level, or maybe even at home care level. But unfortunately, that was not the case in Libya. We went directly to focus on inpatient care, tertiary care centers, highly costing and expensive equipment, ICU medications. That was the main focus, and it will still be like this for years, till we have changing our mindset. Because reform is not in the health sector. Reform needs to start at the minds of decision makers at first. If they do have reform in their minds and they have a new mindset, then they might implement it on the ground. Otherwise, it will stay, as Dr. Murad was saying, it's in paper. That's all. Thank you.
Well, you just gave me a very nice way to conclude this. I think you are right, but I would also say you, with the panel today, to which we will continue this discussion on this topic, are that change as well. And I think everybody in Libya, as much as we will be talking more, and as much as more people in the young generation and the decision makers and the professional experts like all of you open these discussions to the internationals, to the national levels, I think it becomes alive, so that hopefully However Libya finds solution, it will find its trajectory and the way for the benefit of your people. I will organize at some point a round table. We'll invite the key people in the government in charge of the health. Let's open this debate further. And you've been pioneering something that in our attempt to be a sounding board, a platform for your discussions, not our thoughts, but your own, and thinking together maybe some best practices, lessons learned, ideas, maybe saying something that is completely different, but that can craft the project and the consciousness that this can actually come to life. And I really hope that the government will. I still believe and want to believe that after so many years, after you achieved your freedom, and it's a decade since, all of the Libyan people deserve much better. And this what you are doing is a really crucial element that you can be that change as well within the whole structure and system, with all the problems as it is. I want to thank you very, very much. We will all be in touch. I want to thank all our viewers and those who will be watching this later on. We will summarize some of these points in a written form, and we will continue the ongoing debate of how to provide excellent healthcare service, inshallah, for the people of Libya. God bless you. I wish you a nice iftar and Ramadan Kareem, and I wish you all the blessings to you, your families, and the people of Libya for Eid al-Fitr. Ma'as-salam.
Thank you.
Thank you very much.
Thank you so much.
Sasha,
Thank you.
Bye.
bye.